Welcome back to House Healthcare. It is April 23rd, Wednesday, and we're getting an update on Act 115 of 2024. And there was a legislative ask to have an update on that, and we are happy to hear what's been going on. And we have with us,
I guess
yeah.
that's my cue.
Yes, that's your cue. Go ahead.
Wonderful.
Thank
Thank
you.
you. And thank you to the members of the committee for watching our presentation. For the record, my name is Lynn Currier-Stanley. I am the Executive Director of the National Association of Social Workers, Vermont chapter. I am also a social worker, and I'm going to share my screen. I'm hoping you can all see that.
Yeah, Leslie, real quick.
This is more for you. I was just hoping that you might set the table about why we need to hear about this right now.
Absolutely, absolutely. I'm happy to do that.
Okay.
Yes.
Gonna let them set the table.
Act 115 came about a few years ago. Alex Margulies came to me. He was the partner of Leah Rosen Pritchard, the social worker who was killed in Brattleboro a few years ago, asking, is there something that we can do? And I said, yes, we're going to try. And so we asked the legislature to have us put together a task force to review some of the data around social service provider safety and make some recommendations. And this is the culmination of those work groups. And that's why we're bringing, and one of the things in the act was that we would bring it to this committee for presentation. So
thank you. That's
wonderful.
Perfect. And you're reminding, and
yeah, I just needed
remembering the bill to this.
It's all coming back.
I was in a different room a little while ago.
Thank you. Okay, then I will get started. When people don't have their basic needs met, shelter, nutritious food, physical and mental health, they're at an increased risk for a variety of individual and societal challenges. According to 2023 data, 9.7% of Vermonters live below the poverty line. In our state, over 75,000 people are facing hunger. Over 16,000 of them are children. In August of 2024, 51 out of every 10,000 residents were homeless, placing Vermont second only to New York in the highest rate of homelessness in the country. Homelessness can amplify poor mental. Oh, geez. Is the recording coming through?
Yeah. No, it's not. Just you.
You're not hearing the recording?
No. You have to share audio.
I'm gonna stop the share for the second. My apologies. It is doing. Sometimes technology is wonderful, sometimes.
Were you intending on sharing the audio or not?
I can.
I think for time's sake, why don't we just go through the slides and
I am so sorry.
no, we are not hearing anything at all except for you talking.
Okay. Children growing up in poverty have a higher risk of developing a mental illness. Poverty can increase mental illness through disparities in perinatal risk, malnutrition, trauma, social marginalization, and violence. The Cohen Veterans Network found there's a large disparity in access to mental health care based on transportation and location. 42% of people found poor insurance coverage as the top barrier to accessing health care. Provider network shortages, transportation, and inadequate insurance coverage are all barriers to people accessing needed mental health care. While violence by a client against a social service provider is never excusable, given a lack of resources, increased stress levels, and increased mental health challenges, it may be more likely to occur. Meanwhile, social service providers connecting clients with resources, working to alleviate symptoms, and provide mental health care and other services can find themselves in unsafe situations. The Occupational Safety and Health Administration, OSHA, found that in one survey of 175 licensed social workers and directors, 25% of social workers had experienced assault by a client. Nearly 50% had witnessed violence within the workplace, and more than 75% were fearful of violence occurring. In a study of child protective service workers, increased levels of what would be termed non-physical violence, such as yelling, shouting, and property damage, were experienced by 75% of child protective service workers. Physical violence was experienced by 2.3% of workers in the first 6 months on the job. Quality of service to clients is compromised when service workers are experiencing exposure to violence. Attention to safety in the workplace can reduce the level of burnout and help with staff retention. Of particular note is the correlation between transitions and the risk of violence. The Vermont Department for Children and Families found that over half of violent incidences occur within the first week after child removal, in the time between the child being removed from the home and the first visit with the parent or caregiver. Other transitions include the period of time immediately before or after a survivor of domestic violence is away from their abusive partner, where the risk of retaliatory violence against a survivor is significant, as well as violence within the community after being in residential substance abuse treatment, or when a client is transitioned from one agency service providers and another. This might indicate a greater need for a safety net, increased communication between service providers, and more detailed planning. While we are concurrently addressing access to resources, increasing our workforce, and closing service gaps, we must also mitigate the risk of physical and mental harm to our social service providers. We contend that this must be addressed concurrently, as this is a circular problem. Lack of services and resources contribute to violence, and increased violence contributes to the lack of social service providers. The group identified training and systemic supports as key to keeping workers safe. New workers need training in their client population, agency policies and procedures, safety protocols, de-escalation, so they do not exacerbate or create conflict or contention. All workers need ongoing training to address changes in the environment in which our direct workers are operating. While this is true, we do not want to encourage the myth that if social service provider was good at their job, they would be able to talk their way out of any challenging and potentially violent situations. Social service provider training, as found by OSHA, cannot be one size fits all. So much depends upon the client population and where services are provided, whether it's inpatient, whether it's in the home of clients, or within the community. Safety protocols will and should look different. Systemic supports within an agency and between agencies might include scheduled check-ins, support during client transition times when there is increased risk, and bolstering infrastructure to provide capacity, websites with resources, or panic buttons, all depending on the setting and client population. There are a number of barriers to ensuring social service providers have the training and systemic supports to increase safety. First and foremost is the cost of evidence-based safety training, the needs of that to meet the needs of the setting, bolstering infrastructure, and providing quality supervision and oversight. Possible recommendations include expanding some of the private-public partnerships for training that we're already seeing in some milieus. Institutions like hospitals are doing safe workplace violence prevention and safety training for their staff. The Department of Children and Family Service Division is already doing safety training for their workers who are in people's homes and within the community. Smaller agencies can partner with these larger organizations to have their staff sit in during these trainings. We highly recommend that volunteers and support staff are also included in these trainings. Finally, we recommend grants for smaller organizations and agencies to conduct needs assessments for safety training and improvements to infrastructure. Our workers provide invaluable services to our most vulnerable populations. They deserve to be safe and supported. Vermonters deserve to have their basic needs met. Social service providers deserve to be safe. And that is the conclusion of our presentation. This is the list of our contributors and those who sat on the task force. And I am going to stop the share. And I'm happy to answer any questions that you might have. I believe that you have this, this is a PDF.
We do have that. Thank you very much. Leslie, you have a question?
Yeah, thank you. I was just reviewing the bill, and one of the requests in the bill was a set of guidelines, which I think the group was supposed to put together. And I'm just trying to say, is what you showed us the guidelines, but I didn't know that it was the guidelines? Like when you talk about training, are these what you talked about in here, what came out of the guidelines, the recommendations? So, okay, so I was just unclear what guidelines came out of that. And did you submit a report? Because there was also a request for a report in that bill, and I'm having trouble locating that because sometimes I'm klutzy. So if we could find that, that would be helpful too.
I can make sure that I send that. Give me until this afternoon to do that, as I'm jumping into another meeting in just another moment. As far as the guidelines, one of the things that we found is that it's hard to have guidelines. OSHA tried to have guidelines. OSHA tried really hard to have guidelines. And because each milieu is different and the needs of the clients and the workers are different, setting guidelines became a impossible task. So what we're recommending is that guidelines be set based on the organization, that the organization needs to set their guidelines and safety protocols. And this can be accomplished. One of the things that we were requesting is a pilot program to see for smaller organizations that don't have the money to do a needs assessment, a safety needs assessment, to be able to fund some of that so that they can really look at what goes on in their agency and set their own safety protocols and training.
Okay, if I may.
Yes.
So what I'm understanding is that you found there were no overarching guidelines that might apply across the board, that that these organizations could work off of and then make specific to themselves. Is that what I'm understanding?
I believe that there are definitely best practices, but everything needs to be tailored to that organization and the clients that they serve and where the clients are served. There is a part of our work was pulling all of the research together and best practices. but what it really came down to is that there's no one size fits all.
So what came out, I mean, I come from the southern part of the state, very familiar with what happened at Brattleboro, which I think that this bill came out of that horrible, horrific thing. But what I'm hearing you say is that the bill really never moved anything forward.
The bill created the group to come together and look at what some of the issues were and make recommendations.
Okay.
I'm wondering, my question is sort of building on Leslie's question, which was we convened this group to make these recommendations. And I'm wondering if there was value in convening this group and if there's interest in this group moving forward together to keep convening, to come up with, to look and see how things are working, to see how things could be rolled out better, to make further recommendations. I mean, I realize that the bill only tasked you with coming out with a report, but was the value of the work that you did something that all these groups found value in and would like to continue, so that this isn't just a one and done?
Thank you for that question. And to be very transparent, it was not something that we discussed. I can see how there would be value in us coming back together to see what changes have been made to perhaps provide some additional resources to organizations, be able to maybe even work with Vermont OSHA to put up some recommendations and keep track of things and make sure. I mean, it's sometimes about the data that comes in, and if the data that's coming in is accurate and overarching, then we have more that we can work with to see. Child protection does a great job of keeping track of their data, right? Hospitals do a great job keeping track of their data. Smaller organizations have a much harder time, and whether or not where that gets reported. At what level does something need to rise before it gets reported? You know, is it dangerous enough? Is it scary enough in order to be reported? I think that there could be some work done around that.
Daisy?
Thank you for the work that you do. And it's good to be here with you today. I'm curious how our social workers are doing. And even though I appreciate the findings of the group, and you've got some very amazing people on this task force. Yeah. But I'm also curious what NASW and our chapter here in Vermont, is there any way, are you asking social workers how they're doing? Are you collecting any data? And I guess this is like a three-part question. Is there any opportunity to partner with social work students to look at that data and continue to kind of monitor that? Just, can you tell us just loosely, anecdotally, a little bit about each of those?
Oh boy. Thank you for the question. Social workers it's a little hard right now. But as I hear from social workers every single day about the good and the bad, right? So overarching, the social workers are concerned for their clients. And I just a little bit ago did an ethics workshop for social workers at the VA in White River Junction. And one of the things that they're concerned about is that their clients are worried about them They're worried about funding. They're worried about whether or not their social worker and all their other providers are going to be there for them. And I don't believe that that's unusual when we're looking at when funding gets cut. People know that the services that they have been depending upon may go away. So social workers right now are holding on to the stress and uncertainty of their clients at the same time that they're holding on to their own, because some of them don't know if they're going to have a job. As for being able to keep track of data, I always have 3, 4, 5, 6 MSW interns at any given time. They're the ones who did the research, the vast majority of the research for this, before the task force even met. You've got a task that you want NASW Vermont to take on. I personally don't often have the capacity to do it, but they do. So send it along. I'm happy to consider anything. And I'm sorry, there was another question that not sure I answered.
I think you just did answer it, because I asked if you had any partnerships with UVM to do any academic research, and it sounds like you have interns. So
yeah. And I had the great pleasure of talking with BSW students not too long ago. Not gonna lie, they're a little up here about what their future looks like given everything. But my message to them and to every other social worker is we've got a lot of work to do. We've always had a lot of work to do, and social workers are built for this. So that's, yeah, definitely have partnerships with UVM. Thank you.
I really appreciate all that you and your interns are doing.
Thank you, Lynn.
That's healthy.
Appreciate the update, and going to quickly move to Jill Olson. Thank you for your time today.
Thank you. Goodbye.
I'm excited to hear about this because I specifically remember this section of it very vividly.
I'm excited to tell you about it. Okay, good. Good afternoon, or well, technically, just about there. I'm Jill Olson. I'm the executive director of the VNAs of Vermont. Just in the room with me is Eric Covey, who is our director of communications policy and regulatory affairs. I might have gotten that in the wrong order. But if I'm not doing it, he's doing it. It's pretty much how our two-person organization works. So some of you weren't here last year when this bill passed, so I thought I would just briefly remind everybody what this section does and how we got here. So home health in Vermont is, I represent home health and hospice agencies, and we are structured in a way in Vermont that is different from any other state in the country. We have a designated system, meaning that there are home health agencies with local geographic regions. They cover the entire region and they serve all comers, regardless of ability to pay. So whatever your insurance is, they serve everyone, and regardless of, they just can't pick and choose. So in most places, home health agencies have more flexibility in terms of who they serve, but we have this designated system. We think it's mostly a good thing, but that is our system. And because we have a designated system, in addition to the extensive federal rules that cover how we admit, discharge, and take care of people, we have state rules that cover how we admit, discharge, and take care of people. So there's a big set of federal rules. We don't follow them. We literally don't get paid by Medicare. And then there are state rules, and there's also penalties potentially associated with failure to follow regulations. So this piece of statute fits into a much bigger picture of regulation and oversight. And last year when we worked on this, I think there was a little bit of confusion. I didn't really bring that forward enough, so people didn't realize that there's a lot of structure surrounding all of this work. So we brought this language, the language that passed last year, to you because under the designation rule as it existed, if there was a serious incident, a workforce workplace violence incident in a home, the home health agency, if that person came in for a readmission, was obligated to go see them again. So there was no way, after you point your gun at me in the driveway, that the home health agency could say, we're not going back to that house. And we were actually having some issues with things being appealed to the Human Services Board and being required to go check to see if things were any safer. So we just wanted to create a little more flexibility. This was really a flexibility bill for home health agencies to be able to say, once we've discharged you for safety, through all the work we have to do that, there's a lot of process around that. There's an appeals process, lots of oversight. But if we've discharged you for safety, if that person is to be readmitted, the home health agency can decide whether or not they're going to serve that person. So they still might, and home health agencies really try to serve everyone, but they're not going to assess it in person necessarily. They might assess it on the phone. So the bill requires that we, continue to make sure we can't mitigate the situation. We always have to try to mitigate the risk, but there are some cases where we feel like the risk is just too high and can't be mitigated. So that was what you did. You gave us that flexibility, which we really, really appreciate. And what you asked for was just for Dale, but to give you an update on just how many people were actually not being admitted based on this new regulation, and also to give you a little bit of data on how many safety discharges we were doing under the old rule that is still in place. So that's what I'm doing here. So let me just pause there and see, are you oriented? Have I oriented you? Okay, great. Okay. So what we did was, you asked for an update based on 2024. So in early February, we surveyed our members on all of their safety discharges and whether they had used it to deny any subsequent admissions. There are so few of these cases that I'm not writing it down. And I definitely couldn't do it by agency because it's literally no more than 4 or 5, and even at our largest agencies, there are very, very few cases. So what we learned was so far in 24, no one had used the denial of a subsequent admission. It had not happened. I think there has been one since that I've heard about anecdotally, but it's being used very sparingly. This is really more something that helps our staff feel safer. So we can say if something really serious happens, we can promise you, nobody ever has to go back there, right? We can say that. We can, and it's really been more about that than about actual denials of admissions. We also had, there were 16 individuals who were discharged because of safety issues in the home across the whole state. And so just to, and we included Biata in these data. They're not one of our members, but we did a statewide survey. So this is the whole system. Just to give you a little sense of scale, home health does maybe 500,000 visits a year. So it's huge. It's not that many people. It's about, the last data we have, and they're a little old, it's about 6,000, probably about 6,000 people on census on any given day. And we serve maybe, just on skilled home health, about 9,000 people a year. So Medicare beneficiaries. But more.
6,000. Go ahead.
Plus the 6,000 plus 9,000 is 15,000 requires 500,000 visits.
No, I'm saying something slightly different. So there's just different ways to think about how big we are.
Yeah.
One is how many Medicare beneficiaries do we serve? That's about 9,000, and that's just our skilled program. Another is what's our average daily census? How many people are we taking care of on a daily basis as a system? And that's all programs, not just skilled. That's about 5,000 or 6,000 people. It's been as many as 8,000 in years past. And then, yes, takes about 500,000 visits to serve all those people, and miles of drive.
What's the total? I'm sorry.
So none of these numbers are very recent, so I don't want to be overly specific, but I think the average daily census based on old data is about 6,000, and our visits is in the $400,000 to $500,000 range.
Dollar?
That person. Visit.
Visits. Yeah. Not unique.
I'm hungry.
Yeah.
not just you guys are waiting for lunch. Yeah, no, I'm kidding. Yeah,
Okay,
500,000, about
that's-
500,000 visits.
That's a really interesting ratio.
Yeah.
I mean, when you think about the number of visits required.
Yeah, some people need a lot of visits.
Yeah,
Yeah,
that's huge.
Yeah.
It's growing.
yeah, oh, yeah, yeah. So I just wanted to give you a sense of scale. This is a lot of visits, and 16 people have been were discharged in 2024 because of violence issues or for safety issues. You asked for the nature of the risks. And so what I heard from members was there was some physical assault. There was some sexually aggressive language with threats. There was some physical threatening, either cornering or threats with weapons present. Some sexual harassment, verbal threats, verbal abuse, one refusal to secure animals. So we'll come to your home with animals, but you do have to lock them up. And sometimes people just won't. Often they won't secure their weapons either at all. It seems to go together. And then unsafe physical environment, which is a really broad category. So that could mean that there's a lot of active drug dealing happening in the home with a lot of, just a lot of risk in the home, or it could mean the physical structure. But home health goes everywhere. Home health goes to tents. Home health goes to the motels. Home health goes everywhere. So if they say the environment is so unsafe, it's like very, very, very unsafe. And again, lots of oversight if we make the wrong call or do something that someone thinks is not appropriate in terms of the safety. So, and the reasons there's like a few in every category. And among my members, the one thing I was looking for was whether there were any outliers, and I really didn't see any. So the small agencies had 0 or 1 safety discharges. The large ones had 4 or 5. There was nobody who had 15. So it was very spread. And so you would ask for a one-time report, just an update, and just to, I think, make sure that we weren't sort of out of whack with the expectations that you had. And that's what you have before you.
I'm just wondering, did any of these, I mean, I get frightened hearing about this.
Oh, yeah.
Did any of these require law enforcement?
I did not ask that question, so I don't know. I'm guessing some of them did.
Mhm.
Would you recommend any other changes for legislation in the future?
I appreciate that question. We don't have recommendations at this time, but we may at some point come back. Mhm.
Okay.
Again, I think your point that the legislation, even if there's only anecdotally been one, just having it there.
Yes,
Signals to our workforce
that's right.
that we care about them.
That's right. That's exactly right. That was what was really important.
Well, great. Thank you.
Thank you very much. Thanks for the opportunity to